Yeah, and again, thank you, Pascal, for the introduction and the update on the activities in the HOPE network, especially related to the exchange program. And this work on the Beyond Hospital Data project, let's say, was and is initially happening around the HOPE exchange program community, but also HOPE community at large. And really happy to see that the exchange program will be continuing in 2022 after the slight disruption. So yeah, as Pascal said, this is the kind of the outline of the webinar today, and there is now 20-ish of us. So this is, I think, a nice number to have a really good discussion. But before going into discussion, I will briefly present the results of this work so far, and this has been kind of a multi-stage process. But before going into explaining the stages that we did, maybe a short introduction. Why did we decide to discuss the Beyond Hospital Data topic? And in fact, how COVID influenced collaboration and cooperation between healthcare organizations around Europe, and also what happened to data, with this slight focus of what happened to data and how data flowed and still is flowing between hospitals and other healthcare organizations during the COVID. So the kind of the idea behind this project was to continue our collaboration from the 2019 exchange program, but also because of this interruption in the exchange program for 2 years, also to keep in touch with the community, the whole community at large, but by keeping in touch to explore how the COVID situation influenced the community at large and you individually, and also to start talking. And this talking happened in many different forms. Through talking, we also wanted to collect some individual stories or success stories of how the challenge of COVID was dealt with through collaboration, through data exchange. And what we also want to, in a way, focus today is discussing, exploring what this means from now on, so for the future. In a nutshell, this was the idea, and having kept the community together, I think in a way we've achieved at least some of the goals. What we did so far in late 2020 and now 2021 is we've started with this very short, we call it a rapid survey, which was disseminated among the HOPE community on the topic of how COVID influenced collaboration and cooperation. This was done in January and the first half of February. Then in late February, we've organized the first webinar, which, as I said, if you've missed it for any reason, there is a recording on YouTube, and I think it's really an interesting event to maybe review again. Following the webinar, we've conducted a small series of one-to-one conversations on interviews, which we called case study interviews in different European countries on different levels and different people in different positions, discussing on how COVID influenced, as I said, again, collaboration, cooperation, data exchange, and I will present briefly the results of these case studies now for a few countries. And now this is this step, the next step, not the final step again, what we call the follow-up webinar. Again, thank you for joining, and I'll jump right into what we found out so far, and we'll let this be kind of the base for our discussion, and as I said, discussing what this means for the future. So in this rapid survey, we've asked people a sort of a metaphorical question, and that was, how do you see your hospital or your organization in relation to other organizations when it comes to exchanging data during COVID, during the pandemic? And as you can see, minority found themselves being an isolated island, and then the rest were somewhere between an island connected by a ferry boat so let's say maybe an ad hoc communication or as needed, and some or the other half saw their hospitals as islands connected by bridges, so with, let's say, a continuous flow of data and information between institutions. And this was, of course, can be seen as encouraging or positive kind of assessment of the situation. Then we asked what happened to collaboration with other healthcare organizations during, again, during the pandemic. And we see that it did increase. So obviously did not stay the same. Again, this was seen as an kind of unexpected in a way, but also a positive development during COVID. Then we wanted to explore a bit further how this collaboration, especially in relation to exchange of data, happened, and specifically to which organizations. Unsurprisingly, living through a pandemic and a communicable disease pandemic, of course, the collaboration with public health institutions increased, and it happened on almost a daily or real-time basis. And then again, collaboration happened also and increased in a way with other hospitals and long-term care institutions, which played a large role, of course, in the pandemic and still are. And then we see that, which we'll briefly touch upon later on and discuss, the general practitioners or primary care providers, the communication maybe was the least developed one in a way, and it happened as needed, as we can see. We also asked you to provide some kind of positive, what you saw as positive, negative, and neutral developments of the COVID pandemic and exchanging data during the pandemic. And we see that kind of the crisis or the pandemic was seen as an opportunity to collaborate and interact more, especially in an online or a virtual way. We saw that this was seen as a positive test for systems, for data systems and infrastructures, especially pertaining to testing, treatment, and vaccination. We also saw that this drew with it some improvements to semantic and technical aspects of data exchange. So a lot of systems were kind of developed from the scratch or from the existing systems, and again improved links to care and service providers on different levels within institutions and hospitals, but also beyond. As negatives, the survey respondents pointed out that data systems and also governance were still siloed, so separate, and it was sometimes hard to kind of link all that data and link the organizational aspects. That the data sharing did happen, but it was sometimes one directional. So there wasn't kind of a two-way communication stream, and that some noted that data production, a lot more data was collected, but not maybe in an as organized way as they would have wanted or needed, and that maybe I've heard the expression data graveyard, that a lot of data is being collected, but then again, not a lot of it is being used, or only a minority of it is being used. Some thought that nothing changed, and well, maybe still a lot to learn, is not a neutral, but maybe a positive development. But we see that there is more to learn. So that was in a nutshell the results of the survey that we did in January. We presented this also on during our February webinar, and then during the February webinar, we kind of, after presenting these results, we talked to participants. There was around, I think, 40 people present, and everyone kind of agreed that these results do reflect the situation in their countries and in their hospitals and in their healthcare systems, and that indeed COVID did initiate more collaboration and sharing, including the one of data. The reason was because it was needed, obviously, and it did help strengthen existing and establish new connections and relationships, both on the organizational level, but also on the individual. Other findings from the webinar And again, I would encourage you, if you have the time and interest to look at the recording, is that the quality of collaboration and the extent of collaboration, of course, increased, and that throughout the waves of COVID, it became better and more organized and maybe more meaningful, but also that it did depend a lot on the starting point in terms of the data infrastructure. So having electronic health records obviously helped. Having electronic registries and communicable or infectious disease registries also helped. Having a unique patient identifier, so a way of linking data from different sources through one number usually also helped a lot with working with data. And of course, the collaboration, the quality of collaboration depended on the quality of the coordination systems. Nationally, we discussed those, but also maybe regionally and on lower levels. Also, COVID, in terms of collaboration and data exchange, promoted innovation. And we've had a couple of examples of where this innovation was visible, especially through the highly increased use of teleconsultations, both then in developing them technically, but also developing organizational aspects like reimbursement for teleconsultations, so on. And that the whole situation also increased the data timeliness, so that all of a sudden, that this situation kind of made very timely, almost real-time data available, which was in a lot of cases not possible before. However, as I've noted already, and we discussed during the webinar, the communication with general practitioners for various reasons was probably the one that kind of was the most challenging aspect of data exchange in a lot of countries that we've discussed. Yeah, these are the two interesting quotes that I've kind of extracted from this webinar. And one of the participants said, in the future, we'll have more patient data in the hospitals, and I've added beyond, but less patients in hospitals. And I think we can discuss this and see what the situation is also from in your experience and in your countries. And also another quote that I've noticed and kind of liked and wanted to share is that having data is important, but sharing data is what really does create value, I guess, for patients primarily, but then also for the system and providers. After the webinar, we conducted a short series of these case studies in different European countries, talking to people, trying to see some of the examples, usually success stories, but some also mentioned, or all of them, I mean, in a way, mentioned challenges of how this collaboration changed. And I'm not sure whether Linda managed to join. She should be here in the call. We've talked about this experience in Amsterdam or in the Netherlands, where COVID, as she said, created a movement where everyone wanted and had to work together more. And with the role of long-term care homes, long-term care facilities playing in the pandemic, outbreak-wise, but also in a sense of freeing up hospital capacity. And Linda is a manager for a geriatric ward in a hospital in Amsterdam. She explained or showcased this example in Amsterdam, and then later on in the whole North Holland province, where all the hospitals linked together through a system, which I think is called Raha, through a system where they were finally, and this was kind of a long time coming, they were finally able to communicate to long-term care homes and in a real-time manner check capacity and see whether patients needed to be admitted or patients from the hospital could have been transferred to long-term care homes as to free up hospital capacity, which at, of course, some points was highly needed. And I like this quote that due to COVID or because of COVID, nowadays everyone knows a lot more about each other. And this was the case in this example where hospitals really had like real-time dashboards where they could see the situation in other hospitals and long-term care homes. Another example was the one from Poland, where I've discussed and we have Katarina here. for also to tell us maybe more about the Polish experience, but collaboration did increase and there was a lot more data being produced and collected. It was being sent and still is being sent to national level coordination instances, so the Health Insurance Fund and the ministry, and used for kind of the centralized management of pandemic. However, it seems that no really new official systems of communication, for instance, between hospitals were established, but that did not stop, of course, the communication from happening. And it was more on a kind of an individual level where hospitals really did talk to each other and discuss dealing with the situation, capacity, potentially transferring patients. So a lot more, again, data collection, centralized coordination mechanisms, and then the kind of more individual level communication between hospitals. And then what Katarina mentioned was this interesting example of the state government deploying Polish armed forces, so soldiers in hospitals, which did help out during peaks of the pandemic with jobs that needed to be done, but of course human resources were limited and still are quite limited. And we've just in the intro to the webinar heard the situation also in Portugal with the human resources issues and kind of the lack of people and also the pandemic influence it. So people, of course, getting sick and not being able to work. So this was an interesting example or one way of dealing with the kind of the shortages in terms of human resources. Then I've talked to a hospital manager in France, in Paris, which was more about this collaboration between public and private hospitals. And again, I've pointed out this quote saying our financing systems are very different. So we were basically in competition and we didn't really share much information between us. Again, something that COVID changed, especially during the peaks of the pandemic, where on a kind of national and regional level, this collaboration was facilitated more, maybe even forced in a way, having public and private hospital sector at the same table to share information and also to discuss the kind of the provision of care and then transfer of patients, which really did happen. So it would be interesting maybe if there is someone else from France in the call to hear about these experiences. And it seems that this kind of collaboration has continued to this day. So this was a few weeks ago that we've discussed, and the communication and collaboration was still on this level. And again, this was kind of more centrally coordinated. There is another example now in Belgium or Brussels area, where this collaboration between private and public hospitals was more of a bottom-up approach of starting this collaboration with a group of Brussels hospitals, I think 5 of them, 5 largest hospitals having their own group where they would meet and discuss managerial issues and patient transfers, and also shared partly some dashboards where they could see each other's performance and capacities. And then during the pandemic, this group of 5 largest public hospitals in Brussels, or 5 public hospitals in Brussels, also initiated the collaboration with 2 largest private hospitals in the area, where they've kind of added them to the group and continued the discussion in this kind of enlarged group, not at this point, and due to the pandemic again, not focusing so much on the kind of the public-private divide. So that was another interesting example. And then to wrap up these specific examples, the one from Finland, where there seems to have been an interesting development and a relatively good response to COVID, which kind of was explained that happened due to the more municipal level organizational responsibilities. And nowadays, or for some time now, there is discussion in Finland about the healthcare reform, which would kind of lift up these organizational responsibilities to more regional level. And now there is a discussion, excuse me, now there's discussion there on whether this kind of response, which was kind of assessed as being quite good in Finland due to this municipal level governance, whether this could be sustained if the kind of the governance was lifted up to a more regional level. So again, another effect of COVID on a more kind of health system level, but an interesting one. So again, if there are people from Finland, would be interesting to discuss this and hear your opinion. So these were a couple of examples. I would say that very interesting discussions from my side also, and it was interesting to see the similarities, but also specificities and differences between countries in this developments due to COVID. So as I put it here in a tweet, so shortly around Europe, we can say that due to the pandemic, the collaboration between hospitals and other healthcare organizations did increase and improve, and that this often happened in fast, obviously because it was needed, ad hoc, and innovative ways, and even some surprising ways. With these results of our work in the past few months, I would like to open the floor for discussion. I will ask Nick Lazinga to take it from here and to facilitate the conversation. What we would like to hear from you is whether you see these findings as reflecting the situation where you work, in your country, in your institution, in your hospital. Is there maybe an experience that you would like to share in terms of what happened during COVID related to managing COVID patients, or managing also the provision of care besides COVID, and also with regards to data? And yeah, maybe then to discuss what does this mean for the future starting today? How will this be sustained? Will this influence how work is done, how data is exchanged in the future, whether services will change? So those are some of a lot of questions, but I think an interesting discussion nevertheless. So having said that, I give the floor to Nick. Thank you, Nick.
Thank you, Damir, and thank you for sharing all this information. And as you see, we're getting a lot of information that helps us to learn and to get grip on what happens in the healthcare institutes in other countries. And that, as Pascal said, is exactly what of course the HOPE tries to do with its exchange program, that people get insight in the situation of people who are in similar roles in healthcare organizations, but in a different context. So thanks, Damir, for showing the survey results again, but especially for the in-depth case studies, because they very nicely illustrate what kind of changes are happening in our healthcare landscape. And part of the discussion is how do we keep that? How can we sustain that? I suggest I just start asking a little bit more questions to the people who are represented in these case studies, and then open up more broadly. So I understand, Katarina, you are participating in the meeting at the moment.
Here I am. Hello.
Hello. Good to see you, and nice to hear about your, what for us is a case study with your experience in Poland. Could you expand on that a little bit more, especially how this cooperation between hospitals is now working? And actually, I was quite interested, you initiated that during COVID, but you must now be in the position that you have to think about the backlog of patients that were not treated, that will come over the coming months, perhaps the coming years. So to what extent will you keep on exchanging information between hospitals, and will you try to coordinate an optimal use of capacity? And do you have the data infrastructure to help you to do that?
Well, actually, it's quite, I would say, even funny, because all decision we got, it's like very, very quickly, very fast, even during the night. So we received a decision like to open the COVID ward or to create something big, like in a 2 to 3 days. So it was pretty, yeah, I would say even funny and really, really, really hard. So that's the first thing. And the same with the closing ward, like we had already in our hospital. We just closed the COVID ward like a few days ago, and it was like decision, like immediate decision, like okay, we have now really, really small level of COVID infections, of the positive tested people. So now we can, you know, just a decision from the government, like you can, okay, we can close the ward now. So the all
Just to help, and these decisions in your system are taken by the government.
Say again, sorry.
So these decisions are taken by the government?
Yes.
The government gives you instructions.
Well, the government, but the direct decision is from our health insurance, our major, our boss, let's say. But yeah, that's from government. Like they have all illustration of our country. Like they see how many hospitals are with the COVID wards, and then they say, okay, in this area is like, you know, this level of positive test, this area, this, okay, so we can close 5 wards or 5 hospitals, because we had in some hospitals just 1-2 wards with COVID, and then some we had like all hospitals just turn to COVID, the whole hospitals, right? So that's the thing. And about the extent, what change, or what do you want me to say? To what change, or what we expect later?
Yeah, well,
I can talk until tomorrow.
good. Well, then looking forward a little bit. I just want to show that how it functions with you has to do with the governance model that the ministry controls.
Well, the cooperation, it was actually a good idea, because we had like on our area, we had one central station, yeah, with the one person on the phone 24 hours, and it was like really good cooperation between all hospitals in this area. So every single time before we had our ward, or even if we had the COVID ward, and then we had like, you know, not enough space, not enough beds for our patients, we always could call the person and say, okay, let's say we have 40 beds, and that's it, that's enough, and then you can just find the place for our patient. And the person 24 hours on the phone, just look around everywhere, it was like really, really good connection between all hospitals. Plus, we really, really had good relationship, or better relationship than before, with other hospitals, like in neighborhood. So we just could call as well, like, you know, how you do it now, how many patients do you have, like, you know, to help each other, because it was, you know, how hard work. So
okay.
the relationship between hospitals, even if now, you know, the COVID patients we have less patients right now, the really good friendship we turn on, it's like still the same. So we start to cooperate between hospitals. So
what I understood from your case study, that you didn't change the data structure, you didn't change the digital data collection. So
no.
Are there plans to do that? Because is it developed already? Can the central level have a real-time insight in capacity and needs, so that they can do things, or you will keep the data system that you have?
Yeah, exactly. Everything is the same. Nothing changed. Everything is, you know, on computers. Everything is the same.
Okay. So. And how will you do that in the coming 6 months? Because all the hospitals will now be faced with a backlog of surgery, but capacity. Will there still be a kind of central coordination, or is every hospital optimizing its own capacity?
Well, those hospitals who was changed or to turn to just a full COVID, they try to turn back to the same level than before COVID, and it's really hard work. So now, like, you know, when we have, like, you know, no more, or just a little bit, just few COVID wards, now is, we don't use anymore the coordinator, like the 24 hours. So now everybody starts to work, let's say, normal way, just the way before COVID. So it's hard. In my hospital, it was actually not too bad because we had only one word, COVID, and the rest words work normally. So we had like, the surgery and then so on. So we just worked normally plus COVID ward. But those hospitals who had, changed to COVID totally, they have no help now. So, just do it yourself how you can. If you can, just do it. If not, so you know what I mean.
No, thank you. I might come back to you, but I just think nice to compare how you regulated things in Poland with, for example, Portugal. Because Sophia, could you're still online? Yes. Could you put it from mute?
Oh yeah.
Could you compare the situation, what Katerina describes in Poland, with the situation how you manage at the moment in Portugal? And again, I'm trying to find out who takes decisions, what kind of data system are used, and are you going to use this also for the coming 6 months when there will be a lot of demand for healthcare services from the hospitals because of a backlog?
Can I, sorry, I have to interrupt you because I was receiving a phone call from my hospital, from our board. Can you please ask another person, just because I'm meaning that...
I'll come back to you.
Sorry.
Then I would like to ask somebody from France. Is there somebody from France online who can tell us, because there the story was that you included both the public and the private hospitals in doing this. Is anybody who...
Nick, I don't see a French name that I know.
Do you know, Pascal?
Yeah, no, I don't know. I cannot answer. But we have colleagues from Greece, Moldova, Portugal, Austria. So.
And let's go to other countries. Perhaps Greece. Is there somebody from Greece online?
Yeah, there is George, is muted. Maybe we could ask a Dutch. I think there are several Dutch.
That's possible too. I would like to illustrate a little bit the differences, how this works out in a system with public hospitals, with public and private, and with totally different. But we could see, is there anybody from...
We have a colleague from Moldova, Aliona. I don't know if you can answer this because there's a public-private mix in Moldova.
Yeah.
And you are from the private sector, so
Indeed. I am very pleased to see you, dear colleagues. Hopefully we will discontinue this online only format of communication shortly. I look very much forward to the possibility of meeting you again offline. Referring to the question asked, indeed, in Moldova, the steps that have been undertaken by the government in order to address the challenges posed by COVID-19 pandemic, which went quite bad throughout the crisis during 1.5 years. So the management was directed on curing of COVID patients, mostly in public healthcare institutions. And the communication was very much centralized. While listening to our colleague from Poland, I felt that there was quite a lot in common. Indeed, we also had the system of mandatory health insurance, and the budgets increased considerably during the pandemic through these emergent allocations that have been done by the government. The private institutions nevertheless paid an important role, first of all, at their primary level, at the level of general practitioners that were engaged fully. And we have quite a lot of, quite a big number of primary healthcare institutions are private here in Moldova. There was a reform back in 2018. And the cases that haven't been treated in the hospitals, they were covered by the intervention of primary care institutions. So there was quite a lot of interventions done at this level, and we have members of our union that are namely this sort of institutions, a lot of healthcare professionals being engaged both in teleconsultations, but also in face-to-face consultations with the patients that haven't been hospitalized but still treated. It was quite difficult, as telemedicine is not that much spread, and we understood how important is communication and digitalization in healthcare. And now we're trying to do as much as possible to catch up with this in order for the future possible crises of this type to be better managed. So the system was not ready, and communication indeed is quite challenging, difficult, as long as you don't have good informational technologies systematized at the level of the country. As for the hospitals, they were still dealing with emergencies, and there were patients infected by COVID-19 that have anyways addressed the services in private healthcare institutions, but there was no specific system built, so it was mostly happening ad hoc. And as it was said before, the exchange of information was not always well organized, not always well managed. In the beginning of the crisis, like in many other countries, we were all listening to briefings and press conferences that were happening daily, and where you would have healthcare officials participating. And as the crisis went on, the number of these briefings, but also the interest of the larger public decreased. So that was one of the characteristics. And the second, I think it is also lessons that we have learned. The measures that were planned and adopted by the healthcare authorities were not always consulted. There was no time for consultation. Nobody was really prepared. But the institutions and also the patronal unions had to really react to something which has been already approved without being consulted, including the way the information has to be delivered, the frequency the information has to be delivered, the mechanisms that you need to use, and to adjust your own data collection systems within the institutions with the expectations of the healthcare authorities. So I feel that there are so many lessons that we have learned throughout this crisis, and we are trying now with the vaccination at least to avoid the same mistakes that have already been happening during the outbreak of the pandemic. And with the vaccination, we have managed to organize it much better in the sense of not only the practical steps that have been undertaken, but also the information transmission, the information delivery, the information of larger public, the creation of necessary modules for the registration of people who are vaccinated. And now, as you have a variety of vaccines and various deadlines for the second jab and so on, there were some peculiarities. And now I feel that it goes much better throughout the country, not with no discrimination in the sense with the regions and the capital. So it really covers everything at the national level. And I guess that was already one of the follow-ups in a way and correct feedbacks that the system has taken from the pandemic crisis. But I appreciate that Moldova was included in this survey. And I feel that even if the healthcare systems are so much peculiar to the specificity of the country, some general or basic lessons that we have learned, they are quite similar in different systems. And it allows us to design, I guess, comprehensive responses and think of possible reactions that would really fit those different systems, notwithstanding the margins of coverage, being it public, private, whether there are a lot of healthcare insurance systems, or it's mostly a mandatory one that covers the majority of the population. And the system, the information exchange, I think, is one of the basics, the pillars that would be probably now reflected in the upcoming reforms that the healthcare systems will be going through, and I hope that they will be going through in order not to face the same failures that we have unfortunately gone through during this 1.5 years.
Thank you very much for a very detailed prescription, but it's exactly what we're looking at. So what you describe is on the one hand how hospitals react via better sharing of information and optimizing the capacity when you need a large part of the capacity for COVID. But you also bring the element of the change in the delivery model by doing virtual care, introducing apps, digitalization. And yes, that data under that is key, but a lot of these things have happened under pressure in all our countries in the past year. But we now try to find out what the lessons are. So that's why this is very helpful, because I hope you see the similarities with what we heard from Poland, especially on the coordination of hospital capacity. I'll keep the two topics we now have on the table. We have the topic of information exchange for centralized use of capacity, and we have the topic of information exchange with patients via virtual teleconference and others. Could I ask Ireland, because I saw Ireland reacted in the chat, to react on those two things? If you look at the hospital system in Ireland, what happened there with respect to coordinating capacity? And I know you have a mixed public-private system. And what happened in introducing virtual care for patients and communicating about that?
Well, I'll start with, good morning, everybody. I'll start with the public-private links that have been forged in the last 12 to 18 months. We have a very divided healthcare system in Ireland. Private healthcare is voluntary, although nearly 47% of people in Ireland have some level of private healthcare, and everybody in the country is entitled to public healthcare, but it is a very creaking system, led mostly by the fact that we have no unique identifier in this country for people. So information exchange between GPs and hospitals, and obviously hospitals and private hospitals is very difficult. So we really were in a pickle when COVID struck. However, a call was put out at the time for people, for the private sector to step forward and volunteer to help in struggle against the pandemic. And most private hospitals did at that point become public hospitals, and they were designated as public and COVID-free hospitals. And for the first part of the pandemic, we were very successful in managing this. Although the numbers of people presenting at hospitals, maybe this was experienced in all countries, fell. People were afraid to go to GPs, they were afraid to present at hospital ED departments, and we had quite a quiet period from in an acute hospital setting, really, for our patients, apart from COVID. However, last Christmas, in Christmas 2020, this country mistakenly believed that we had seen the last of COVID, and we opened up very rapidly. And we unfortunately have just finished 5 months of a very difficult lockdown. Difficult because we couldn't get cooperation with the public because they did not want to go back into lockdown, and difficult because there was no designated period of time as to how long it would take to recover. We are just beginning to emerge very slowly and very cautiously from the lockdown. The public and private system have rearranged their cooperation. I believe it is working better in that the private system is allowed to work again as a private system, but we have designated 10% of our patients' beds and 10% of our surgical space and 10% of our radiology and so on to the public system. Patients then on waiting lists are being designated with unique identifiers that are shared with the hospital, the private hospital, where they will go for their care. And the information is flowing backwards and forwards quite well with that. Unfortunately, you may be aware that we then had 2 weeks ago a cyber attack on our public system, and our public system's IT system has been shut down. Email between public and private hospitals has been shut down, and we've once again been challenged with trying to care for patients. So what I could say about the future for public and private healthcare in Ireland is that we would hope that the lessons learned from the pandemic are definitely going to lead towards greater cooperation. We absolutely must recognise the need for a unique patient identifier that travels with the patient no matter where they access their healthcare. But most importantly, we need to have a good link that cannot be broken by cyber attack between the public and the private sector. And we're struggling, and that's what can I say? We're struggling with all of those things. So it's going to be a very challenging 12 months for us from the point of view of trying to recover. We are seeing an increasing number of late presentations of very serious cancers. We're seeing, you know, an increasing number of late presentations of cardiac disease. And our patients are having difficulties with accessing care. So it isn't the happiest place to be, but I think the communication that was forged during the original part of the pandemic is certainly going to help with planning the future. So that's us.
No, thank you for sharing that, and then the frank overview of what you're facing at the moment.
Yes.
So you see it's very similar what other countries experience. It just manifests itself quite different depending on your governance structure, your data infrastructure, and yeah, perhaps the capabilities of dealing with that. Just one follow-up, you speak about recovery. Is there already a recovery plan, and who's in charge? Who is coordinating it?
Yes, so the Department of Health is generally, we have a number of of divisions within the Department of Health. There is the public health section. There would be a designated COVID section. Vaccinations are being looked after by a section in public health, and they are excellent at communicating their progress. A paper has just been published yesterday on the resilience and recovery plan for the country, with a large part of that including healthcare plans. So the government struggles with healthcare plans because budget is difficult, and private healthcare is strong. It is strong from the point of view, and that takes a lot of budget capabilities away from the public system. So at the moment, the government, through the Department of Health and communications with the private hospital insurance authorities, are negotiating plans to cover the major illnesses that are currently in need of acute attention, and that will be led really by the Department of Education, the Department of Health, and the private hospital institutions as a group will negotiate as a group with the Department of Health. There is a There's a plan previous to COVID called Sláinte Care. Sláinte is an Irish Gaelic word for health, and that was always beginning to be implemented, where there would be much greater cooperation between the public-private healthcare systems, and I think they will try and fast track that. So they will. I personally work in a private hospital, and we have been very successful we believe in our assistance. But we're based in a city, and we have a number of major hospitals around us. A number of our consultants work in both locations. They work publicly and privately, and that has made us a good location for the department to link with us. It would be difficult for smaller private hospitals that don't work so closely to a city where they are very much independent and maybe are fully staffed by private consultants. It's difficult to imagine how they could link in so easily with the Department of Health now. I think it's a 5 to 10 year plan, really. We're not going to meet any kind of a deadline in the next 12 months, I would say, in this.
Thanks very much. Very clear. Can we have the situation in other countries? Sophia, you're now in a position to talk, because I think that the experience in the Portuguese hospital sector is quite similar than what was just described.
Sophia, is unfortunately on the
Not-
phone with her
is there
board. So.
another participant from another country who can share their experiences?
I don't know if George is back, George Timopoulos from Greece. Any other Portuguese colleague? I see 3 at least.
In the meantime, when you're considering responding, of course, the whole purpose of having these kind of discussions and exploring is to see the similarities. And what I am aware that a similar story can be made for Belgium, especially for Flanders, where during the first phase of the pandemic, also the exchange between hospitals was set up more stringently. There's actually a nice evaluation report that prescribes the whole exercise of how the Flemish hospitals coordinated capacity and also had to overcome existing boundaries, management boundaries and boundaries between different types of hospitals. And it was good to see that in the case studies of Damir, that is one of them. I can also say that in the Netherlands, you see it a similar phenomena where although all the hospitals are private, not for profits, there was a very central approach towards planning ICU capacity and COVID capacity. And both in Belgium and in the Netherlands, the underlying data infrastructure was a topic of concern, because most of these data systems were not designed to have real-time insights in capacity. And then same in the Netherlands, they had to set things up. They use it in the National Registry of Intensive Care Units to use the system, but they're now also in the turning point of thinking how to use this and if to use it for optimizing the existing capacity. We heard from Ireland that there is a backlog in some cancer types, there is a backlog in certain elective operations. So it might well be that the coming year, if not longer, you still have needs to see whether you should distribute nationally certain capacities. One of the things that I observed was that, for example, in Belgium, in Flanders, although they coordinated everything, there was not a transportation from patients from one hospital to another, COVID patients. Whilst in the Netherlands, given a very strict capacity of ICUs, that very early in the process was part of the mechanism. So we had ambulances and even helicopters totally infection controlled, bringing patients from one part to the other. And of course, those are changes that need a good underlying data system, but also have an impact on the way how you organize your hospital care. And in that way, now should be thought through to see how over the coming periods that willingness to cooperate is actually assured and can be built into the system again. Looking at other participants.
Well, I can say a few words about France now, since it's
please.
no French, but some of the elements that were presented are familiar. France has a very competitive public-private system, and private means not-for-profit as well as for-profit. And in some part of the care, like surgery, for example, the for-profit has a very high number, almost 50% of surgery. So in that situation, it was, and to say something important also, the ICU beds are in the public sector, and that's the situation. So the issue was not so much in ICU. At some point, the private sector was asked also So very limited number of ICU beds were used in the system, but clearly almost 80% of COVID patients, ICU and non-ICU, went to the public sector, which is much higher than the 65% of the share of the public sector. So that's one first thing. Compared also to what you said about the Netherlands, the French also organized circulation of patients of the country and also outside of the country. So the significant numbers were inside France, but there were some outside France. They organized even trains to do this. In the first wave, they actually didn't do it so much in the second wave. That's interesting also because of the complexity of organizing this. So let's say they were better prepared in the second wave not to have to do it in that sense. And to come back to a more general issue about the way systems are organized, the competition between the public and the private for-profit in particular is still an important factor to have in mind. It was presented in the slide on France that Damir had gathered from the French participant. It was an issue of tension also because in the backlog issue that you mentioned, and it's very big also in France, cancer, cardiovascular disease, and strokes, and so on, the private sector was able to quickly recover much quicker than in the public sector. So there was some worries about losing market shares in some aspects. So and that was an underlying factor also important to keep in mind. In terms of communication, the situation is improving, but it's far from being perfect in terms of communicating between the primary care and the secondary care and the hospital care in France. And of course, it's not at all working well between the public and the private hospital sector. So that's something that is in the plans for many years, may improve thanks to the pressure of COVID, but it's far from being optimal on that aspect. And finally, on telemedicine, yeah, it exploded in France, like in many other countries. We don't know if it's going to be back to the pre-COVID numbers. Certainly not. I think some people will continue to work that way, since there has been a reimbursement system put in place in France that facilitated also the development of this. So there's pressure on this, but we don't know yet what will be the future of this new way of working.
Thank you. That's that's very informative to get the broader picture. If I summarize the discussion, it's very rich, but there are two main components we discussed. One is the sharing of information between different types of hospitals, public, private for-profit and not-for-profit, to optimize existing capacity. And we heard different experiences there, and it was reflected in the governance models and in the data systems, and we're all struggling now to do that. And as you heard from a few countries, it already means, like you just said, Pascal, that for some emergency services or ICU services, that it is decided that those are public functions and they should not be a private function. So that seems to be one discussion. Another discussion seems to be the whole influx of teleconsultation and virtual consultation. So the different way of the hospital to relate with the patient. And I like the quote very much from Damir that you got from one of your interviews. In the future, we will have the data, but we won't have the patients. This has accelerated communicating of linking specialist medical care, the knowledge, with people being in totally different places, at home or wherever. So that's another area which will of course depend very much on the data exchange and to what extent you have a data infrastructure that facilitates that. It might also pose some inequity problems with part of the people not being able to deal with that, to hand it. And then actually I was in a totally different debate yesterday, which was in the Netherlands, where one of the main directors of the University Medical Center in Utrecht said, well, we're developing lots of apps now to capture the data from the patient, but we have to put in health literacy components to that too, to make sure that people can be reached and know how to handle this. But in essence, we are busy redesigning the processes, or the working processes in our hospitals. So two themes that link to that. Perhaps a third one, but I noticed that Linda Rombaerts was not in the field. Another way is not just how the hospital relates to other hospitals in primary care, but surely also to long-term care. And we saw that in many countries now and that's why I very much like the example, Damir, that you brought of the data exchange between the geriatric departments of the hospitals with the long-term care facilities. Because if you optimize that data flow and the information, it can, on the one hand, avoid unnecessary admissions to your hospital system, but it also helps the long-term care facilities to get the expertise and the knowledge how to handle COVID patients. So that was also a very good innovation, which materialized in a data infrastructure, and in a way linking broader towards long-term care and social care is also what you see in the case study from Finland, where they actually increased the data exchange on a municipal level. So although we're all still in our own experience and things and trying to do as good as possible, it helps to take some distance and see the general patterns that seem to emerge in the various countries. So I think that's very rich, and that's, I think, one of the nice things that can be done with in the context of HOPE, in an European Hospital and Healthcare Federation, where you can, make these case studies into a more broader analysis of what is happening with healthcare delivery, and especially what does it mean for data exchange. I think we exchange a lot of good ideas. I just want to open up for a last round of reactions before I hand back to Pascal. Is there anybody who would like to add to the discussion or give another country example? And again, it might be, there will be other opportunities for people to get in touch. Again, when you feel uncomfortable now speaking in a webinar, but you have a story to tell, don't hesitate to connect with Damir, because we really like to have these various case studies, but also help building the broader agenda. What are the themes that should be discussed as part of HOPE, but also as general themes that are of interest in an exchange programs where managers from one country and one setting go and see how it functions in another one.
Yeah, thanks, Nick. I also wanted to maybe add on that, is thinking of the 2022 exchange program next year. Are there any, I guess there might be people here that plan to join the exchange next year, or maybe also for Pascal to reflect, will the whole situation in the last year and a half, how will it reflect on the exchange program? Do you think that then people within the HOPE community visiting other countries will feel closer to what happened in other countries? Because I mean, we've all been and still are in the same situation, but then the way systems and institutions and hospitals reacted, how much will that be a talking point during the future exchange programs? So maybe that's
yeah, no, but it was the point I wanted to make. It's that we have then hopefully the Open Exchange Program 2022 starting on the 9th of May with final Agora on the 3rd and 4th of June. And as we do every year, we have a topic for the Agora, but is also something that participants are looking at during their stay. And that, like we did with you in 2019. The next step for us is with national coordinators when we meet in November. So as I said, the deadline for applications of hospitals and participants is end of October, and we're meeting 3 weeks after. At that meeting, we do the matching on the basis of, as I said at the beginning, on the basis of participants accepted in 2020 and newcomers, new candidates. We will discover at the end of October. And the other element to answer your question is that at that meeting every year, we discuss the paper as we did for 2019. We discussed the paper that is giving a sort of overview of the Agora topic, which is again not the topic of the exchange. The exchange has no general topic, but this topic of the Agora, that we definitely continue the discussion we have started in 2019. We are continuing with both webinars and the work you're doing, Damir. So clearly at that point, we will be able to give a better picture of what will be the topic. End of November is not the end of the decision. We are working then on in a couple of months later. So that means that before participants go to the exchange program on the 9th of May, they know, they have a clear picture of what is the topic of the Agora and what things they will looking at. So of course, for everybody, COVID-19 will still be there. Hopefully not the virus itself, but more the consequences of the backlog work, the consequences of new ways of working that have been identified. We've heard a lot of more flexibility and more coordination. So all those subtopics will be definitely in the discussion of the Agora. So next step, continue the work with you and with colleagues who want to provide more case studies as you asked for. And then ending up by a clearer picture of what is the topic and what then later will be the structure of the 2 days we are organizing in Brussels, 3rd and 4th of June 2022. Face to face, of course.
Thanks, Pascal. And I think that is a kind of good closure. So I leave it in your capable hand to close the meeting. But not before saying that I was very happy with all the input. And I know we are all under a lot of pressure in our own systems to do things and to balance personal life with our work. And that pressure has not gone. The good news is that things are opening up. COVID is under control in most of our member states. And in many countries, summer is coming. But for the healthcare system, there is a huge backlog and things that has to be addressed over the coming months. So it is important that we have these discussions, that we try to pick up on the lessons learned and also use the HOPE infrastructure as one of the fora where this can be discussed. So thanks for all your input, and Damir will of course follow up. Perhaps then I think there are some remarks made that a few more case studies could be added to your portfolio, but then we will wrap that up and make that available as a document. And Pascal, really looking forward to continuation of the overall discussion.
Yeah, thanks a lot, Nick. Thanks, Damir. Thanks, Diane, for supporting HOPE in this work, and you did a tremendous work, and it's not finished. We still have a lot to do. We'll continue to work with you also for the Agora next year, that's obvious, on this. Thanks a lot for all participants, also national coordinators who could make it, As Damien said at the beginning, I forgot to say before, but since it's registered, since it will be on YouTube, we will circulate the link to all our network. So not only the participants national coordinator, but also in overall OPE mailing list, so that people can go there and check what has been said during this meeting. And of course, there will be more papers coming also around the results of today and the previous work done. So I hope to see you face to face soon, national coordinators at least in November, and participants hopefully also in May 2022. So wishing you a nice end of the day. It's not finished, and a nice weekend following this. Bye-bye.
Thank you so much.
Very
Goodbye.
much.
Have a good
Take
day.
care.
Bye.
Bye.
Bye.